Our patient is a 66-year-old male who presented with jaundice, and he underwent a cholecystectomy 6 months ago. The procedure was complicated by stones in the common bile duct, so a drain was placed to keep the duct decompressed. That drain was removed about a month ago, and shortly afterwards he became jaundiced again. Imaging showed a stricture sitting high in the biliary tree, where the left and right ducts meet. And this is a recognized pattern referred to as Post-Cholecystectomy Mirizzi syndrome. Classically, Mirizzi syndrome occurs when a stone in the gallbladder or cystic duct presses on the neighboring bile duct and squeezes it shut. Here the gallbladder is already gone, but at the same junction, scar tissue is formed and is now strangling the duct in just the same way. So essentially, we're going to look at how we get into a bile duct that's completely closed, even when your imaging can't show you a way in. So before we touch anything, let's have a look at this ERCP. So this shows us the ducts just before any instruments go in. Up at the top, there are the hepatic ducts. So you have your left, right posterior, and right anterior hepatic ducts. Those ducts then join at the hilum. But I want you to notice how full and swollen they look. So that's bile backing up with nowhere to go. And lower down, we can also see the duct here again. As we mentioned, the duct is visible above and below, but look at the segment in between. At the level of the stricture, there's just nothing to see. And that absence is the whole finding. Essentially, the scar has sealed the duct completely. And here's just a dynamic illustration of the same problem, so you can see where the flow of bile stops. So moving on to the intervention, you'll see that to reach the bile duct, we first have to get through the papilla. And this is the small opening where the duct drains into the duodenum. Normally that means cannulating it, but here the papilla won't cooperate. And in a case like this, where you have scarred and distorted anatomy, that's not unusual. That's the first real obstacle that you face. So we escalate, and this is a needle knife pre-cut where instead of going through the natural opening, a fine cutting wire is used to make a controlled incision through the papilla, and this provides us direct access to the duct. And you can see how bile wells up from the incision. That efflux is the goal because it tells us that the cut has reached the bile duct and that we finally have our way in. And so the first real lesson of this case is that difficult biliary access requires stepwise escalation. When the standard approach fails, you don't abandon the duct, you just move up into a more advanced technique. And the needle knife pre-cut is one of those steps. So now we try to map the route by injecting contrast, and you'll see that the lower duct fills, but if you pay attention to the stricture, you'll see that the contrast just reaches it and stops. And this is what we refer to as silence, and we can inject all we want from below, but the narrowing won't let anything through. It's not ideal, because it means that we have no channel to follow and nothing to really aim the wire at. You'll see the wire being pushed up towards the stricture, but it just loops back on itself again and again. No amount of force at this point will get the wire through. And that's really the crux of this case, because fluoroscopy can only show you where contrast can go, and here contrast can't go anywhere past the blockage, so its utility is really put into question in this case. So the key here is to stop pushing blind and instead to bring in a cholangioscope or the SpyGlass. And this is just a tiny camera that's passed directly inside the bile duct, and for the first time, you can actually see the duct itself. Straight away you'll see how it shows the face of the stricture with a pinhole, and this is just a tiny opening in the scar that fluoroscopy couldn't reveal because it was far too small to hold any contrast. So it's interesting how the camera found in seconds what the X-ray couldn't show in 20 minutes. But with the opening in plain sight, we can bring a catheter straight to it and aim instead of guessing where the channel is. So a fine guide wire, just 0.02 of an inch across, is threaded through that pinhole and across the stricture. And it's worth being clear about what this wire is doing because it's easily misread. The wire isn't cutting anything and it isn't widening the scar. Its only job is to cross the blockage and establish a route that every tool from here on will follow. With the wire across, we can now switch back to fluoroscopy. Remember, the X-ray only went silent because nothing had crossed the blockage, but now that the wire's through, we have the roadmap and fluoroscopy can guide everything that follows. Contrast is injected again and watch the upper ducts as they fill. The same injection that produced nothing earlier now lights up the system above the stricture, and so that serves as proof that the blockage has been crossed. Over that wire, a dilator is passed into the narrowed segment to stretch the scarred channel open. And this is done in steps, gradually, rather than forcing it all at once. And it's referred to as sequential dilation. It's just gentler on the duct. So now the channel that contrast couldn't enter at the start of the case is open wide enough for it to pass through. These fine dark lines threading up and curving into the upper ducts are guide wires that are placed in both the left and right sides of the liver. And there's a clear reason for this, because remember that the stricture sits high up at the hilum, where the duct divides into left and right. And so a blockage there threatens both halves of the liver's drainage. If we only open one side, the other would stay blocked, and that trapped, undrained segment is exactly where infection takes hold. So it's important to secure access to both systems so that the widening and the stents can be built over these wires. And that's actually another important lesson, because for a stricture this high, you have to think about the whole biliary tree, not just the first channel that you reach. Now comes the final step, which is holding the duct open for good. The larger device that you see being advanced over the wire is a stent on its delivery catheter. The thin guide wire that was placed is now doing its real job by acting as a rail that carries something much bigger up to exactly the right spot. And this is why every earlier step mattered, because you can never push something this size through a sealed pinhole. The wire made the roots, the dilation open the channel. Only now can a stent pass across the stricture. A stent is inserted into the duct and deployed, leaving it behind to prop the narrowing open so bile can finally drain. And because both sides were secured earlier, you have one stent for the left system and one for the right. So this case leaves us with 4 things to take away. Firstly, difficult access is a stepwise escalation. You climb to the next technique rather than abandoning the duct. Secondly, you can't wire what you can't see. Thirdly, fluoroscopy and cholangioscopy are partners. Each is used for what it does best. And lastly, for a stricture this high, you drain every territory.